So the first thing I wanted to talk about is just why is drug pricing, an important issue, and why is it something that folks have continued to talk about. And I just wanted to start with some very high level statistics. I mean, I think the biggest thing is everyone on the line probably has personal experiences, either themselves or their family, being impacted by the cost of drugs, sometimes being unaffordable to the point that you can't even get them when you need them. So some of the stats that are out there, first, for the patient, about half of Americans regularly take prescription drugs. And of those, about a quarter of them say that it's difficult to afford those drugs. And that's from a Kaiser poll, I think, in 2019. And then one of the other general quirks of the American drug pricing issue is that Americans pay about twice as much as other countries for the same drugs. So some folks, one of the arguments is maybe Americans take more drugs than other countries, but no, in reality, our utilization is about the same. It's just that we happen to pay twice as much. And I'll try to go into some of the reasons why that is. And then for the healthcare system as a whole, drugs make up about 14% of the total healthcare spend, and that percentage continues to grow. And right now, we're spending about almost $500 billion. Well, in 2018, we spent about $500 billion on prescription drugs. About 335 of that is in the retail setting. So, for example, going to your local neighborhood pharmacy, the drugs that you can get there, or 165 billion in physician-administered drugs. And these are drugs that you have to go to the doctor's office and have them administered. Next slide. So I wanted to start with this, and hopefully you can read everything on here. I included the website in case you wanted to take a quick look. But this is a diagram from Adam Fine's Drug Channels blog, and it's worth taking a very close look at this diagram if you want to learn about these issues at all. I think the first thing I would take away from this slide is just the overall complexity of the pharmaceutical supply chain. And that also just means that since this is such a complex system, there is no easy answer and there is no silver bullet. I think I also want you to take away that there is no bad guy in these scenarios, quote unquote bad guys. I think this is an extremely complex system. And I would basically say that every entity within this supply chain is reacting to, providing the exact appropriate reaction to the incentives in the supply chain. Everyone's doing exactly what you would expect them to do based on this system, the incentives within this system. So I wanted to quickly go over the diagram. I'm not going to get too into the weeds. We could literally spend this entire evening just talking through this diagram. But I did want to provide a kind of high level overview so you can see the major players in the supply chain. So when you go to the pharmacy at the bottom to pick up your drug, you can break it down to the movement of the product, which is primarily on the left side, the wholesaler and the manufacturer. And then I would also separately look at the payment for the drug. So we'll start with product movement, and this is the easy part. Basically, the manufacturer makes a drug, they sell that drug to a wholesaler, the wholesaler sells a drug to the pharmacy, and then the pharmacy sells the drug to the patient. And that almost sounds like any other commodity that you can think of. And then if you were paid in cash, that's it. You basically just pay the amount at the pharmacy, and that's a closed system. But this introduces kind of the first quirk of the drug supply chain, and probably, this is also comparable to the rest of the healthcare sector. But if you're paying cash, you're paying substantially more than insurance would be paying for an insured patient. So that's to say that patients paying cash are paying the most. They pay something close to what is the list price, when really insurers pay the pharmacy back at even just a fraction of that cost. So the craziness starts when you're looking at this diagram. If you look, pardon the background noise, sorry. The craziness starts when you look at the payment side. If the patient's insured, then that basically means that the patient is on paper kind of tracing this line. So we're going to the right, if you can follow that. But basically the patient pays the insurer a premium to cover the drug. The payer then hires a pharmacy benefit manager, which were basically an unknown entity until relatively recently. And their job is basically to manage the pharmacy benefit, and that's both the administration and paying of claims, but most importantly nowadays, it's the development of the formulary. And what a formulary is basically a list of preferred drugs, and manufacturers need to pay rebates to PBMs to get onto that preferred list, and that basically drives volume towards your drugs. And then ultimately the PBM reimburses the pharmacy at a negotiated price, and often the net price after these rebates, again, is going to be substantially less than the cash price that a patient would pay just going to the pharmacy. So as you can hear from that word salad that I just threw at you, everything is extremely, extremely complex. It does make it very difficult to kind of pull levers to try to make drugs more affordable. So next, I wanted to provide a quick history of how we got here. So we can go to the next slide. So I think one of the things to take away is that the prescription drug market is a very unique market, and there's a number of different issues that make it kind of act the way that it's acting. I think, first of all, you'll hear this from manufacturers and proponents of innovation and things like that, is that prescription drugs are one of the most highly regulated industries in the world. And I just listed some of the key milestone legislation. This isn't even the tip of the iceberg. I just wanted to flag each of these because it does feed into the conversation. So first, there was the Food, Drug, and Cosmetic Act, which basically created the FDA, and it started with a requirement that drugs be safe. Then there was the Kefauver Amendment, which required that drugs be shown to be safe and effective. And I also wanted to flag the Hatch-Waxman Act, which gets into a lot of the rights around generic drugs. It basically created the distinction between name brand and generic drugs, and created an abbreviated approval pathway for generic drugs. And through the Hatch-Waxman Act, we created kind of the social agreement that we would pay a lot of money up front and give drug companies a monopoly to reward them for innovation and the risks that they take for bringing a drug to market. And then in return, once that exclusivity is gone, it then goes to generic, and then you get the drug for pennies on the dollar. And it almost effectively becomes a universal good to everyone. So you reward this investment up front as a name brand drug, and in the end, it becomes a generic drug and freely available to everyone. So those are some, so that's just to say that there's a lot of continuing policies that regulate the market and also make it very difficult to break into the market. Also, as I mentioned from the Hatch-Waxman portion, drugs receive a government granted monopoly to recoup their investment. Also, drugs require a prescription, so that gets rid of some of the market forces and competition that you would expect if you're able to freely choose between products. Also, you'll hear that drugs are extremely expensive to bring to market, so they have extremely high failure rates, and their estimates range from $314 million to $2.8 billion to bring a drug to market. And then the last thing, I've alluded to this in the last slide, is that the market is extremely complex and extremely secretive. So it's actually very difficult, if not impossible, for folks to actually know what a drug costs. We know what the general list prices are, but there's almost no relation to the actual price paid for the drug. So the complexity of that system allows kind of a lot of I don't want to say funny business happening behind the scenes, but it just basically makes it very difficult to pin down exactly where the issues are. Next slide. Okay, so I wanted to start with this quote. While this country has the best drugs in the world, it would appear from the great number of letters which the subcommittee has received that many of our citizens are experiencing difficulty in being able to purchase them. And I don't think we have a poll set up, but I would love to, I want everyone to kind of just reflect on that quote and take a guess on when we think this quote is from. As you can see from the quote, it's a subcommittee hearing in the US Senate. It sounds like it could be from yesterday, could be from the 2010s, could be from the 2000s, could be from the 1990s. Pat, did you want to hit the button? Well, this is from Senator Kefauver in 1959. And the one thing that is very interesting as you go back and just kind of read and learn about these issues is that we've been having literally the exact same conversation since before the 1960s, and all of the talking points are exactly the same. I'm going to reference another report when I introduced something called the Medicaid Drug Rebate Program, and you could read that report from 1989, and it sounds like it's written today. So it's just unbelievable how these issues continue to exist. So next slide. So again, just kind of, if you're asking me for the 2-second history of why drug pricing is the way it is, basically until the 80s and 90s, it was kind of haphazard how drugs were covered. Often drugs were not covered at all by insurance, and then it was often just a ad hoc benefit that was provided. kind of to attract different patients, but it wasn't as universally covered as it is now. And then we reached the 1990s when we hit kind of the golden era of blockbuster drugs. And these are where some of the true mega drugs came from. But even then, a lot of those drugs, you were talking about a cost in the hundreds of dollars a year, thousands at the worst case scenario. But obviously, we're now in the world of tens of thousands, hundreds of thousands, millions of dollars for a drug. Then, I wanted to flag a few policies that just kind of put weird, incentives into the system and had potentially some unintended consequences. So I'll walk through those very briefly. One is the 1990 Medicaid drug rebate program, which created the best price rule. The 1992 340B program, the 2003 Medicare Modernization Act, which basically created Part D. Then, one thing that I think is important is the general rise of PBMs and consolidation. Then also the 2009 Affordable Care Act, and then the 2010 Affordable Care Act, and then also the rise of specialty drugs. So I'm going to briefly cover each of those issues. Next slide. So in 1990, I referenced this report. There was basically a subcommittee report in 1989 that from the Subcommittee on Aging, which basically said the high cost of prescription drugs is basically bankrupting states. This is just a catastrophic issue. But again, you read through, it's the exact same talking points that we have today. And it is just interesting to see how time is a flat circle. But we, so this report came out, and as a response, the Congress put together something called the Medicaid Drug Rebate Program. So again, the idea was that Medicaid was paying so much for drugs that it was functionally bankrupting them. So they needed to create this program where they could get drugs at a discount. So what would happen is at the end of the year, Medicaid would get a rebate to ensure that they basically got the best price that manufacturers charge to any commercial customer. And there's some restrictions to that and tons of technical detail. But basically what it did is it made it so Medicaid was paying the lowest possible price for drugs. However, it had an unintended consequence because manufacturers were actually giving a number of different discounts to different groups, including high-need physician practices or in hospitals and things like that. So what happened was basically, hospitals serving high-need areas, the prices got raised so they didn't trigger best price, so then they could no longer afford their drugs. So that created the next slide, which is the 340B drug discount program. And what that does is it allows qualified entities, which is, you can think of it as basically hospitals serving high-need patients, to acquire drugs at a very, very discounted price. And then they can also charge the full price. So it's almost like a profit mechanism for hospitals that are serving high-need patients, and then they can use those resources as they see fit. There's a lot of debate and delve in the details on the 340B program, but I did want to flag that, it's a program that functionally allows substantial hospital systems to get drugs at a deeply discounted price. Next slide. Another major milestone was the 2003 Medicare Modernization Act. So as I've mentioned, prior to this, prescription drugs were not covered by Medicare. They were covered in the medical benefit, but most prescription drugs were not included. But as these blockbuster drugs started to come to the market in the 1990s and commercial plans started to make it more routine to cover prescription drugs, Medicare felt like they needed to take action. So they created the Part D program. And I'd say, I forget what it is, maybe 60% of Medicare beneficiaries have Part D coverage on top of their Part B as in boy coverage. Now, a few key things to note of this is that the Medicare Modernization Act included a provision that prohibited Medicare from negotiating drug prices. And this is a big part of the conversation that we're hearing today. You'll hear, the federal discussion right now is talking about how we should allow Medicare to negotiate for drugs. And functionally right now, the Medicare is just told a price to pay and they just pay it. The drug companies literally kind of set that price. It's a little more nuanced than that, but that's one of the reasons why we pay so much more. And basically the argument is Medicare subsidizes private companies to negotiate on their behalf. They manage their own formularies and things like that. But folks would argue that negotiating on behalf of the entire Medicare population would allow for much deeper discounts. Also, there's just a bunch of weird quirks in the Part D benefit, and a lot of them have kind of been cleaned up over time, but there are some that still exist. So I'm not sure if anyone remembers that donut hole. Luckily, that has been phased out, but that was kind of a budgeting exercise where you would have very generous coverage, then you would go into this donut hole, you pay the whole thing, and then you go into catastrophic coverage. And no one thought that that was actually a good plan design, but it was more of like a budgetary trick to get it passed, and ended up with, what I would say is a major pain point for seniors that were using the Part D benefit. Also, there's a weird quirk in the catastrophic phase in that Medicare covers 80%. And then I think the patients cover 5%, and the payer, the subsidized insurer, only pays 15%. And what that means is there was kind of this race, and currently still is, a race to get into the catastrophic. So then Medicare is the one that's taking on the brunt of the very, very expensive drugs. So that's another kind of quirk of the payment system. And then also another problem is there's no out-of-pocket max. So again, this was kind of designed for drugs in the 2003, not 2021. So there are a number of different issues within the Medicare Modernization Act that have caused, caused some of the issues around drug pricing. Next slide. Then in the 2000s, this all kind of goes together, the trends of the blockbuster drugs and the biologics and specialty drugs and PBMs all kind of goes together. But as I mentioned, pharmacy benefit managers kind of started these as these quaint little organizations that would basically manage pharmacy benefits. And they also did some minor formulary work, but it was primarily a claims processing organization. However, in the 2000s, there was kind of like major consolidation. And these are now literally some of the biggest companies in the entire world. They've grown into multi-billion-dollar organizations. And this trend has largely grown in line with the growth of rebates. And I think I might talk about it right here. So basically, as I mentioned, the way that manufacturers get onto formularies to get volume driven to them, or volume means like getting more people on their drugs, is they pay rebates to the manufacturer or to the pharmacy benefit managers. So what happens is the way manufacturers increase their list price so that they can give bigger rebates. So there's something called the gross to net bubble, which Adam Fine coined. I already referenced him earlier. He was the one that had that diagram in the beginning. But basically what's been happening is the net price of drugs, and this is up for debate, but what people hypothesize is that the net price has been going up in that kind of 3 to 5, the like kind of 1 to 3 range for the past 5 years or so. But the net price, the list price has been going up by 5%. And what happens is it allows manufacturers to give more rebate dollars back to PBMs. So now we basically have kind of this $135 billion slush fund of just amorphous money floating around. And that's what a lot of folks point to as one of the major drivers of at least the complexities of the supply chain. Next slide. Also, it's important to flag the Affordable Care Act, which basically kind of just put gasoline on the fire in a number of situations. It increased the number of insured, and basically the more people you have insured, the better their coverage is going to be. So there's going to be more people on drugs. So it just increases drug spending. It also dramatically increased the 340B program. So the reason that's an issue is because manufacturers will say, hey, like, we're giving out so many 340B drugs that we need to increase the list price for non-340B to make sure that we're getting the same profit. So basically saying that they're giving out all these discounted drugs means they have to charge wherever it's not discounted to make the same level of profit. And then another weird quirk is that it caps something on I mentioned the Medicaid drug rebate program. Back in the day, before the Affordable Care Act, if you increase the drug price too much, you could actually have a negative rebate to the point that you are paying Medicaid when, like a manufacturer, rather than getting paid for a drug, is actually paying Medicaid for that drug if they increase their prices too much. But the Affordable Care Act got rid of that and basically said the most that you can give in a rebate is bringing that drug price down to 0. So that got rid of a lot of kind of like tamps that we had on drug inflation prices. So you've just kind of seen this explosion since 2010 in drug prices for all these different reasons that I've outlined. Next slide. And then the last thing I wanted to flag is just the rise of specialty drugs. So defining as specialty drug is more of an art than a science, but basically it's any kind of high cost drug, one that requires complex care or complex molecules, which is a biologic versus a standard small molecule. And this is where we're seeing a lot of the real explosion in growth and spending. And also this is where a lot of your front page news, very expensive drugs are. It follows the kind of the Pareto principle. So in 2004, they made up about 20% of all drug spending. In 2015, that went up by 10% to all 30% of all drug spending. And the important thing to note is only about 2 to 5 patients are taking specialty drugs. So these 2 to 5% of patients are making up about 30% of all drug spending. And this is a continuing issue. And there's a number of different nuances to that discussion. Next slide. So I wanted to just leave us today, and I know I threw a lot at you, and I'm happy to go into the weeds on any of these issues. Again, if any of this sounded interesting or you really want to get in more, I would recommend those 2 books that I referenced. But basically where that leaves us is we're in a state of market failure. We talk a lot about how competitive markets will drive down prices. A lot of folks will say market force is a potential solution to making drugs more affordable. But basically what we have is a broken market. So you have new drugs coming to market that are tens of thousands, hundreds of thousands, or now even millions of dollars a year. And then more importantly, essential drugs that have been on the market for decades can cost 2 to 3 times as much as they did when they first came to market, because there's no there's been evergreening and extensions of those monopolies. And then also there's no consequences to rampant drug inflation. And as I mentioned, the list prices have been exploding to allow them to give bigger rebates to the PBMs. And then finally, that leaves us where we are, where patients are often expected to spend more and more of their out-of-pocket dollars to make sure that they can afford the drugs that they need. So that's kind of drug pricing in a nutshell. And now I wanted to start talking through some of the solutions for these issues. So I'm going to turn it over to Jim to talk about the work that AARP has been doing.
Thank you, Andy. It's a pleasure to be here, and on behalf of AARP-Maryland, and it's nearly 900,000 members in the state, to tell you some of the things that AARP is doing and trying to do on this issue. I did want to first acknowledge the presence in the audience of our state director, Hank Greenberg. He's always been a great backer of actions that we're trying to take in this field, and you'll see that there are a lot of things that we're involved with at this point. The next slide, please. First, just where Andy kind of left us off is we now know why there is a problem. And just to recap some aspects that are useful for the next part here. Why are drug prices so high? Because they can be. There's nothing really stopping the manufacturers in most cases of raising their prices. And that I'm talking here about the commercial and Medicare markets. The Medicaid market is a different set of circumstances that Andy outlined very well. And he's also explained the role of the PBMs and the distributors as middle people, middle men, and how that figures into that. One area he didn't get into in too much detail, although he certainly raised it, was pharmaceutical patents. Your basic patent for pharmaceuticals lasts 20 years from the filing date. But that doesn't mean when that period is over that the drug necessarily will be off patent. There are numerous techniques for stretching the patent life. Some are as easy as adding an additional ingredient and filing for a whole new drug and therefore a whole new patent period. And those things have been done. Next slide, please. Okay, what is AARP trying to do about the problem that Andy described so well? One of the biggest measures is support for a particular piece of legislation, H.R. 3, who's actually renamed in favor of the late Congressman from Baltimore, Elijah Cummings. And that bill actually passed the House in 2019, but it has never to this date gotten a vote in the Senate. What would it do? It would authorize Medicare to negotiate drug prices. That's obviously one of, if not the major provision, but there are lots of other ones. Set maximum prices for insulin products, and 25 single-source brand name drugs in 2023, and that number would go up in 2024. And it states what the prices would be, which is no higher than 120% of the average in 6 industrialized nations. So we're not trying to cut off the profit for manufacturers. We're just trying to put some sensible limits on it. Very importantly, this bill would also apply in the commercial insurance market in most cases, unless the insurer opts out, and that gets a little more technical, and I think we need to go here, but I'm glad to try to answer questions on that if there are any. Very significantly, it would reduce annual out-of-pocket spending threshold to $2,000. As Andy explained, there is no out-of-pocket maximum in Part D now. You do, after a certain amount of spending, $6,550 in 2021, get to what is called the catastrophic phase. And after that point, you're paying only 5% directly, if you can call that only, because it's still a lot of money. And the rest would be primarily paid by Medicare, but the insurer would pick up 15%. But there's no maximum. And this could go over, and as new expensive drugs come out, it does go over into really big amounts of money. So this bill would be designed to do something about that. Another provision, expand the eligibility of certain premium and cost sharing subsidies under Medicare Part D. This may be a little bit too technical, but I'm glad they field questions on that afterwards. Another significant provision would be that CMS would, and that's the Centers for Medicare and Medicaid Services, federal agency, would have to issue regulations directing that direct-to-consumer TV ads for covered drugs include the list price of the 30-day supply of the drug. Why do we want that? Because you can get really psyched up for getting a drug that's advertised in television, then find out what the cost is only when you're at the pharmacy. And we want consumers to be informed about that. Next slide, please. Okay, what else has been happening? And there's a lot of things happening lately, and I'm going to try to update some of this with material that's not in the slide briefly. But this is not a partisan issue. The Trump administration itself proposed a rule for a demonstration project, and only a demonstration project, which means it's small scale, that would put the prices for certain Part B drugs. And when we say Part B, those are drugs generally given in a physician's office at the average paid by several foreign countries. That rule never took effect. The pharmaceutical industry has sued to halt it, and basically it's been overtaken by other events. What else has been happening? Legislation has been introduced to bar pay-for-delay agreements, which slow down development of generic drugs. Let me briefly explain what we mean by that, because pay-for-delay is one of the more insidious reasons that drugs are as high priced as they are. If you get near the end of a patent period, and that means after that period, the brand manufacturer loses its monopoly, and other manufacturers can produce the same chemically identical drug for a fraction of the price. Brand name companies have been going to the generic companies and say, hey, wait a second, you don't really need to do this now. Why don't you wait a few years and I'll give you some financial inducement for waiting a few years so you're not really hurting yourself. And that has happened many, many times, so much so that the Federal Trade Commission says those agreements cost US consumers $3.5 billion a year. Okay, getting into the Biden administration now. He issued an executive order in July that directs his administration to work with states to devise plans to import medicines safely from Canada. Let me take that part first. Well, I'll just mention briefly, it would also have the Federal Trade Commission ban these pay-for-delay agreements. Importing medicines from Canada has been an issue for a long time. Canadian prices are way below US prices, even though we're next door neighbors there. Nobody can really explain any logical reason for the difference to be that great. The argument against it is, oh, if you import them, we can't tell that they are go through the same scrutiny as drugs here go through the Food and Drug Administration. Well, Canada has a very good system of approving medicines itself. We're not talking about third world countries here. We're talking about countries that have been shown that they can be a safe source of drugs. So this is an issue that is also still very much alive. Next slide, please. Okay, more recently, President Biden said just last month he wants a penalty for drug producers that raise prices faster than inflation. He would also put a firm cap on the amount Medicare beneficiaries have to pay for out-of-pocket costs each year. Remember that there is no cap now in Part D. The best you can do is pay 5% of the cost of a drug, which for drugs that costs tens and hundred thousands of dollars, and there are such drugs, that's a lot of money. He also wants to make it more feasible to import lower cost prescription drugs just from Canada and to accelerate development of generic and biosimilar drugs. What are biosimilar drugs? These are not identical the way generic drugs are, and Andy can correct me if I'm misexplaining this, but they are, for all practical purposes, like the same drug and with the same effects and side effects, so that you can use the biosimilar drug with confidence. Next slide, please. Before I get into these latest national developments, AARP, and I just got off a call with their state volunteers regarding national issues, is going to be a week of action on this issue. AARP will have a number of things going on, but it also wants consumers to send copies of their receipts for high-cost drugs. Don't send the actual receipt, just a copy, to congressional offices. That's part of the way we want to make sure that the members of Congress know how this is affecting you and affecting all of us. Okay. Also, we want to try to make sure that there's some effort to counteract false information that's flowing around, and I'll get into that false information in a moment, but the congressional Democrats have pending, and AARP is a nonpartisan organization, so I want to make clear we're not supporting one party or the other here. We're supporting certain issues here. And there is a $3.5 trillion budget bill. This is the so-called soft infrastructure bill that is separate from the $1 billion roads and highways type infrastructure bill. One of those provisions would enable Medicare to negotiate on drug prices. Remember from Andy's presentation that the Medicare Modernization Act specifically precluded that. So we would need to change the law to have something done about that. And the expectation there is that not only would this lower prices directly in the Medicare market, but because Medicare is such a big factor in the overall market, it would apply impetus to lower those costs in the commercial market, and there would be things to help that process along. To no one's surprise, the pharmaceutical industry is against these provisions. And you may have been watching television lately and seen some ads. It doesn't identify who really is the backer of the ad that said, well, basically, if this happens, you will reduce access to prescription drugs. There's absolutely no evidence whatsoever that that is the case. And one of the items that AARP mentioned in the call today, the national leaders want people to do, and what they will be doing is trying to make sure that people are aware that there would not be a change in access to drugs if this kind of legislation passed. So that is a more recent development. Okay, next slide, please. Okay. What is AARP doing and has done at the state level? And I've had the pleasure and honor of being involved in some of these efforts in the most recent years. One thing that was kind of a separate and distinct issue, and that's why I wanted to mention it first, is AARP testified and lobbied successfully for a state law that removes so-called gag clauses in contracts between pharmacies and PBMs that prevented pharmacists from answering basic consumer questions about, is there a lower priced alternative to this brand drug I've been prescribed? And pharmacists knew the answer to that, but depending on their agreements with the PBMs, with the wholesalers, they would not be allowed to speak about it, or they could basically lose access to the drugs. Well, that Maryland did enact the law, and that is no longer the case. You can ask your pharmacist, and the pharmacist has no reason not to answer that question. Next slide, please. Okay. Then we get to the actual price levels of drugs and what's been happening at the state level. First major action occurred in 2017. There was legislation which was widely supported, and the state attorney general helped write this bill that would have prevented price gouging on certain prescription drugs by limiting the price that could be charged for them. It's really straightforward. You can't charge more than this amount. Okay, that bill, which had a lot of provisions that limited, this was not every prescription drug in the market, it was just a relatively small number of high-priced and very important drugs that we were talking about here. Okay, that bill was allowed to become law. The governor did not sign it, and under Maryland law, if the governor doesn't take any action for a certain amount of time, the bill does become law, and that's what happened here. Immediately, the pharmaceutical industry sued. And the law actually survived its first court test, but the pharmaceutical industry appealed, and the appeals court panel, and it was a 3-judge panel, actually wasn't even unanimous on it, but in a 2-to-1 vote, they said, no, this bill this law cannot remain in effect because its rules violate the so-called Commerce Clause of the Constitution. Commerce Clause basically regulates items that are in interstate commerce. And the concept there was, since drugs may be produced in one state and go through wholesalers and other forms of distribution, they're in interstate commerce. Maryland appealed the decision, but the Supreme Court, which of course does not have to take cases, and in most cases they do not decline to take the case. So basically, that law was not ever able to do anything. Next slide, please. Okay, AARP, and along with its partner, and I want to cite prominently that partner's name because they've done great things on this legislation. Maryland Citizens Health Initiative, which is headed by a force of nature named Vinnie DeMarco, worked on and actually helped bring someone who had lots of pharmaceutical industry experience to help write this legislation that said, okay, if we can't regulate the prices that are charged, let's instead regulate the prices that are paid, and moreover, limit that to the prices paid by government entities, which we are clearly in a position to do something about. And so that was the legislation that was enacted overwhelmingly in 2019. But along with that, it was not going to be just for the government entities for a long period of time. It authorized the Prescription Drug Affordability Board, and Andy will talk about its role specifically right after I finish this portion, could extend its authority to the commercial market beginning action in 2023. What is the PDAB? Again, Andy will go into detail, but keep in mind that this is the first such entity in the nation. Maryland is a pioneer in this field, and other states are constantly looking to Maryland to see what is going on there and to see what they might be able to do based on Maryland's experience. The legislation did provide a small amount of initial, but no permanent funding for PDAB's operations. And as a result, PDAB basically had to beg and borrow to get itself going with some good help from the Maryland Healthcare Commission. Next slide, please. Okay, in 2020, one of AARP's big missions, along with the Maryland Citizens Health Initiative, was to try to get permanent funding for the PDAB and do it in a way without use of any taxpayer money. So there would be no argument that could be made, hey, you're using money for this group that's unproven and hasn't done anything yet. The bill would, and I can say at this stage, would fund, but of course the bill does fund PDAB by assessing small annual fees, and they are small in relation to the size of these organizations, on businesses that are in all parts of the pharmaceutical production and distribution chain, including manufacturers, PBMs, and distributors. That bill passed overwhelmingly, but it was vetoed by Governor Hogan. The reason he cited was he did not want to raise taxes during a pandemic-caused downturn. The problem there was that there was no tax hike involved there, and it really did not involve any taxpayer funds. And with that in mind, the General Assembly overwhelmingly overrode the governor's veto in 2021. So that kind of brings us to where we are now on AARP's action. And now it's back to Andy to talk about PDAB.
Great. Thanks, Jim. So that is a great example of how you can work with the legislator to get legislation passed. And I'm happy to be sitting here before you, working for the entity that Jim was so instrumental in creating. So I wanted to just give a quick overview of the Maryland Prescription Drug Affordability Board, our upcoming work, and then how you can get involved, and then also what you can do on your side to help make prescription drugs more affordable for you, your friends, and your family. So next slide. So I can't beat Jim's overview. So I appreciate the history there. So just very quickly, we were created in 2019. And it's actually in our legislation that our mission is to protect state residents, local governments, commercial health plans, healthcare providers, pharmacies, and other stakeholders within the healthcare system from the high cost of prescription drug products. And we are made up of a board of 5 members, and we're supported by a 26-member stakeholder council. And we meet bi-monthly on the 4th Monday of every month. We actually have one coming up in September, I think the 24th or the 27th. The 27th. So for anyone that found this to be an extremely interesting presentation, we would love for you to jump in on our next meeting. Next slide. We have a 5-member board. The chair was appointed by both the president and the speaker, and that's Van Mitchell, previous health secretary of Maryland. The governor appointed Dr. Joe Levy, a researcher out of Hopkins. The Senate president appointed Dr. Renee Pavel, who is a practicing ophthalmologist. The Speaker of the House appointed Dr. Abiria Nukuga, who's a health services researcher out of the Maryland School of Pharmacy. And the Attorney General appointed Jerry Anderson, who's a nationally renowned expert out of Hopkins working on drug pricing policy. And they serve a term of 5 years. Next slide. And we also have the Stakeholder Council, which is 26 members. Each member is representing a very specific part of the supply chain. And their purpose is to provide stakeholder input to assist the board in making decisions as required by the law. And they have a term of 3 years. Next slide. So what are we doing right now? Our immediate work is to write 2 legislatively mandated reports. One is to study the aspects of the pharmaceutical supply and supply chain. And then we also have an annual report identifying drugs that need a cost review based on causing affordability issues. We also have a report due on generics in January 2022. And then the actual kind of meat of the authority we have is to set upper payment limits. So first, the board must decide if it's helpful to Marylanders and for the benefit of the state to set upper payment limits. And then if they do decide that, then we would create something called, we would create an action plan to set upper payment limits. So that would be kind of the next iteration of work that we do. Next slide. So this study of the supply chain is basically going to be an overview of the Maryland prescription drug spend in different areas that are causing affordability issues for Marylanders. And then also we'll be looking at policy options on how we can make drugs more affordable. And we've been given the okay by our board to look as broadly as possible. So while we do have 3 policies we're going to specifically look at, specifically upper payment limits, reverse auctions, and implementing bulk purchasing processes, The big crux of what we'll be doing, well, just as importantly, I would say, is a kind of a portfolio of recommendations. So we make sure that all of the policies that we're putting together kind of work together and really do try to make an impact on making drugs more affordable. And this report will go to the Senate Finance Committee and Health and Government Operations Committee in the House, or House Government and Operations Committee. All right, next slide. So the one thing I wanted to end with, and Jim's going to elaborate on this a little bit more, is just what can you be doing now? So obviously there's all these policy levers that Jim and I have discussed, but as a patient, there are things you can be doing right now just to make sure that your drugs are more affordable. First is to make sure you have the right insurance, and especially if you're in the Medicare space, it's very important to be picking the right plan. And I think Jim will talk about this shortly, but always double check, especially during the re-enrollment or the enrollment period. Make sure that you're putting in the drugs that you're taking and then finding the right insurance. Next, you want to also make sure that you work with your prescriber to select the right drug. So if you find that there is a drug that is causing you affordability issues, bring that that issue up to your prescriber, and you can look and see if there are other more cost-effective alternatives. Now, obviously, if you found a therapy that works for you, you want to stay on that therapy. But if affordability is an issue, it is something you should discuss with your physician, and then you can see if there's something that may have the same therapeutic effect, but may be much more affordable for you. And then finally, there are patient assistance programs, both from the nonprofit sector and even the pharmaceutical sector, that help patients that are having issues with out-of-pocket cost spending. They're usually limited to patients that have insurance, but it's definitely worth looking for assistance programs for the specific drugs that you're on. And then if you need more resources, we're always available, so you can contact me and we'll try to plug you into any local resources that are available to Marylanders. Next slide. And then, so that's what you can do as a patient. And then what can you do as an advocate? A lot of this aligns with what Jim had already flagged, but you can become one of the advocates and one of the policy experts. So let your legislators know that this is an issue for you. It's very important to share your stories and experiences. There's nothing more important to me as a policymaker and implementer to hear the on-the-ground stories from patients. So please feel free to share those stories, and that really will move the needle for a lot of the different policymakers out there. Also volunteer to help others that are having issues affording their drugs, and then also volunteer to support the Maryland Prescription Drug Affordability Board in our work. We'll continue to make those opportunities available, so please do reach out and let us know if you're interested in supporting us in any way. And with that, I'll turn it over to Jim to talk through some more specific examples of how to help with prescription drug affordability issues. Jim?
Thanks, Andy. And before going into this part, just briefly, I think, and I trust everybody got a sense from Andy about how good this board is, because I've listened, I've watched the bi-monthly meetings. This is a board that is really working and looking at all possible approaches. And it's got backing from all facets really of the public. The members were really well chosen, and Van Mitchell is a former state health secretary who really understands this field extremely well. Andy, with his background both as an attorney and as with a doctorate in pharmacy, is the right person for this too, and it's really putting Maryland in a great position for it. Okay, this next portion here, I need to make clear that I'm taking off my AARP hat here and talking just personally and largely from what I've seen and done as a Medicare prescription drug plan counselor for the State Health Insurance Assistance Program. If you're not familiar with that program, it's a good one to get familiar with, because they supply counseling by people who have good backgrounds to do it, and who are all volunteers except for the two staff people. And particularly as you get into the open enrollment period, and we're just about getting into it, I'll cite the specifics there. This is the time when you want to get some help if you have particular questions, and lots of people have questions. Okay, so let's go to the next slide and start with this. And let me preface this briefly, but I'm going to start and spend a lot of time on Medicare, largely because this is the part I know most, but also because we are heading into the open enrollment period. The open enrollment period lasts from October 15th to December 7th. And that's when you can elect a new standalone Medicare prescription drug plan for the following year. There are some exceptions which would allow you to do it at different times of the year. It usually involves if you're getting extra help subsidies. And if you're in Medicare Advantage, which is the particular portion of Medicare where you have a private plan rather than original or fee-for-service Medicare, then you have additional time to do that. I'm not going to get into detail on that unless there are questions, but this is primarily for people who are in original or fee-for-service Medicare, and they have or want to have their own standalone prescription drug plan for Medicare. And a lot of this is stuff that you can do yourself, and I would encourage you to do yourself because it's not that complex on the basic portions. Part of it is, and also it'll give you a good idea what questions to ask, and then you can ask people for questions. Just don't do this on December 6th because you may not get the answers in time. If you go to that web address, and for those of you who don't have it on your screen, www.medicare.gov/plan-compare. You can create an account if you do not have one, or if you already have one, just log in. And as soon as you log in, you will see information that comes up that will be of use to you. The first thing you may see is whether you're getting any federal financial assistance. That's called Extra Help Program, and there are two forms of it. There is full extra help, which is really designed for the poorest of the poor, generally people who have both Medicare and Medicaid, although there are exceptions to that. And there's also partial extra help, which more people qualify for, but there's still fairly stringent tests in terms of both income and assets. Make sure that information is correct. And if it's changed, if you don't have extra help this year, but you're going to have it next year, you need to make sure that that is reflected in the analysis you do. And certainly if you have extra help and you're losing it for next year, that also changes things and you need to adjust for that. Within the past 2 years, that site has been improved, so it'll come up with a list of prescription drugs that you have taken. You will find, if you take, especially if you take quite a few drugs, there are some of them that you took in the past, but you don't take anymore. Unless you expect to take those again, wipe those out, because otherwise the results that come up are not going to be that useful to you. What you should be left with is a list of the drugs you are currently taking or expect to take. I put on ones that I sometimes take and sometimes don't because I want to know what the maximum cost is going to be. And make sure you got the right dosage level and the number of times a day you take the pill. If you take them less than once a day, there are ways of adjusting for that. And just make sure that information is updated. Okay, what the Plan Finder has done for 2021, and it's as always the case that there are changes being made up until the last minute. So I don't know for sure what the case is going to be for 2022, but the indications are you will be allowed to select 3 pharmacies plus mail order, and mail order sometimes saves you money and sometimes it doesn't. So you really need to run the analysis that you would consider using. And you don't have to worry about finding the exact CVS or Walgreens pharmacy you use. If you're in Maryland, the pharmacies of those chains will have the same prices, and that will be generally the case for other chains. Next slide, please. Okay, what you can do there, once you have that information in there, is you can have the computer run an analysis, and it'll let you look at what the best plans may be in a number of different ways. To me, the most useful is total costs. If I'm looking only at the cost of the drugs, but not the monthly premiums, I'm not getting an accurate representation of what I need to know. Similarly, if I'm looking just at premiums or deductibles, I'm not getting it. To get the whole thing, look at premiums, look at drug expenses, look at deductibles, make sure the pharmacy that you want to use is a preferred plan. There's also called standard in-network plans. I think Medicare is working toward eliminating the concept of standard and just having preferred and not in-network. But for this year, you still may be seeing preferred pharmacies and other network pharmacies. And generally, there'll be a fairly substantial cost difference if you use a preferred pharmacy, but you got to look at the individual case. Okay, next thing, Maryland has its own form of financial assistance. And one of the things I like about this is it's not based on assets that you may have. In other words, if you have a giant insurance policy that has a cash value of $100,000 or so, that doesn't count when you're figuring whether you're entitled to this senior prescription drug assistance program. It will give you an amount off of the premium up to $40, I believe it was for 2021. I don't know what it'll be for 2022. There are also some cases where it can do other things, but getting a little more in the weeds and too complicated, I think, for this. So I'm glad to try to field questions. Another thing that I find useful and I would recommend is check the star ratings for the plans. Those come out in mid-October, so right before the open enrollment period starts, and they are assigned by CMS based on what its data shows has been how well the plan handles such aspects as claims, appeals, customer service requests, etc. If you're dealing with a 3-star plan and a 3.5-star plan, there's probably not going to be much difference. If you're looking at the difference between 4-star plans and 2-star plans, that is definitely a factor that you should be considering when you decide which plan you want to use. And then, of course, pick the plan that best meets your need. You do have till December 7th to change your selection. People I know have changed it multiple times for that, but just make sure on December 7th that you have the plan you want, because that'll be your plan starting January 1st. And in most cases, there are exceptions, you will not be able to change it in the following calendar year. Next slide, please. Okay, when you're using this drug finder, some specific things to look for, and I'm going to get into commercial aspects shortly, but this is still Medicare here. This is new. Starting for this year, there were plans that offer a $35 monthly copayment for insulin. And if that seems like a lot of money, then you haven't been taking insulin, because prices for insulin drugs have been skyrocketing and going into, in some cases, thousands of dollars for some of the newer products. So these will cover basic insulin products, but including the newer products, and your monthly copayment would be $35. However, not all drug plans offer that. The so-called basic drug plans, which generally have lower premiums, don't. Enhanced drug plans, which generally cost a little more, do, but they generally don't cost $35 a month more. So this is a worthwhile savings if you're on insulin for any reason, generally diabetes, but also for other reasons. And it's worth checking out if you haven't done that. Then look at the findings that we just mentioned before about preferred versus standard cost sharing in your pharmacies. You'll find very often the difference is huge. You want to try to use a preferred pharmacy if you possibly can. And it gets more complicated because most of these companies have multiple plans, and they may have different preferred pharmacies in each plan. For instance, I have an Express Scripts plan, as does my wife. We have different plans because of the nature of the different prescription drugs we take. And her drugs are cheaper at Walgreens, mine are much cheaper at CVS. So we go to different pharmacies, but that's something we had to find out for ourselves in the plan finder. Okay, for brand name drugs, and this is something Andy alluded to, most producers have some financial assistance programs for users, but that you really need to meet very tight financial criteria. So don't count on this, but at least look at it. And you can look at it on Plan Finder. It has the information on this. And for those who qualify, the financial benefits are pretty huge. So this is something you want to do as part of your research. And also note which tier each of your drug is on in each plan. What do we mean by a tier? A tier, and Andy explained the concept of formulary. It basically explains how the plan regards your drug. And tier 1 or 2 generally are generic drugs. Often these days, they are not subject to a deductible. So this is what you want if you possibly can get there. Tiers 3 and 4 are usually brand name drugs. Tier 3 is a preferred brand name drug. It unfortunately gets even more complex by this. There's a tier 6 that are also particular kinds of drugs that there may be favorable arrangements for. But the main thing is find out which tier each of your drugs is on, and then you could find out which plan is best for you. Next slide, please. Okay, look for special situations in the Plan Finder, results affecting your drugs. And never just assume something that your brand name drug is going to be less in a particular plan, because if you look in detail, you may find out that certain drugs, for reasons known only to the plans, are much less expensive in a particular plan. Why? They've done that process of negotiation Andy described and worked out a real favorable arrangement either with the producer or the PBM, and so they can offer it for less. But you got to look at it to see it. Okay, then kind of the bad news here. If your family income was what I would say is very high for at least most families, meaning over $174,000 for 2 spouses filing jointly, and that's for plans in 2021, but it's based on your tax filings in 2019. So for 2022, it'll be based on your tax filings for 2020. You will pay higher monthly Part D premiums under what is called the IRMA provision. And I probably know what that acronym is, but I'm not even going to try at this stage. But it basically means you're going to pay extra money. In 2021, that extra money was $12.20 a month in premiums. I do not have the figure yet for 2022, but it should be out shortly. Next slide. Okay. If you need assistance, and this is where the time of year is absolutely right for this program, this is what the SHIPs are for. You can get free appointments to counsel beneficiaries. And I've mentioned before, the counselors are unbiased volunteers. They usually have specific backgrounds in the area. And for drug plans, you have to be certified in that area, pass a test. So you're speaking with people who know what they're doing here. If you're in Howard County, you'll see the phone number on the screen. For anyone who doesn't have it up, it's 410-313-7392 to set up an appointment. They will set up appointments for the next open enrollment period starting September 27th. So you can't get it yet, but if you put that date in your calendar and call them starting then, you'll be able to do that. I was hoping to tell you that all of these appointments this year will be in person, which was what the SHIP was hoping to do. Now that is up in the air, and I think it'll be at least partially remote. We're hoping it won't be totally remote. But again, this may be changing right up to until the start of open enrollment. Last year, we had to do it entirely remote, which makes it a little harder. I can't show you things on my computer quite as easily when I'm doing it remotely, even if you have your computer open. But in any case, both options, I think, will be available for next year. Next slide, please. Okay, last, as promised, I wanted to look at some special situations that apply not only in Medicare, but also in commercial markets. And I have one that I'm going to add just based on something that occurred to me this week. But the big thing is that prescription drug producers often have unpublicized arrangements that can lower substantially your prices on specialty drugs. Here's an example on this on Medicare, but then the next ones will then take into affect the commercial market. I had a colonoscopy in July. I had to use a preparation drug called Sutab. If I had gotten that through my Medicare drug plan, it would have cost me hundreds of dollars. However, my physician was aware and made me aware that there was a $40 manufacturer's coupon if I obtained the drug directly from the manufacturer. Why do manufacturers do it? Well, they avoid a lot of their middle costs, and it's worthwhile for them, not to mention that they get the names of potential patients for future use. Okay, that was on Medicare. But here's where things apply in other places too. There are discount plans available. A couple of them that I'm familiar with. One is GoodRx. Another one is AARP-Optum-Rx. That sometimes, but far from always, offer better prices than either commercial insurance or Medicare on certain drugs, especially higher priced drugs, where they have agreements with the manufacturers. It costs nothing in the case of GoodRx to get their card. You can do it from their website. I'm not here to praise them or push them, but just know that it's one of them, and there are others as well. If you're a member of AARP, and we certainly hope you are, then you will have access to the AARP Optum RX discount card. And that sometimes will have better prices. Most pharmacies accept GoodRx coupons, but on many drugs, their prices are higher than you may have on your insurance, whether you have Medicare or commercial insurance. So the bottom line, again, is you got to check it out. Okay, and I think we've got one last slide here, and I'm going to cite my example there. Okay, just along the same lines, here's the case that came up in just the past week for me. I have a gastrointestinal problem that I flared up, and I need some fairly expensive kind of suppositories. Called my pharmacy, found out, well, I pretty much knew this from the last time I got the drug 5 years ago. It's not on the formulary. Not on the formulary means it's going to be expensive. Specifically, it was going to be under $832 for 30 suppositories. Okay, first thing, and I had a helpful person at the pharmacy that helped guide me in what to do. You try to get prior authorization through your physician. In this case, I was able to get it. That lowered the cost to $550. It's still a lot of money here. All right, let me see if I can do better with GoodRx. Nope, $718. That's even worse. That's almost as bad as the regular price. Tried the AARP Optum, $273. Look at what a big difference. That's basically half the price, even with the prior authorization I got. Just go through the steps here, look at whatever discount programs you have and see if you can do better. And in this case, it's not going to be processed through my Medicare benefit. It's going to be processed separately, and like it was a commercial market transaction. Okay, other things you can do. If there's a drug that is in a high formulary tier that's going to be a ton of money for you, ask your drug plan sponsor if your physician can make a case that you need that drug, there's no real substitute, and that therefore it should be covered on the same basis as a lower tier product. Very often this will happen, but you got to have the case made, and you really need your physician to make it for you. Okay, I was told we might have in the audience some Maryland state employee retirees. If we do, first, you have my sympathy for what you've been going through in the last few years with what's happening to your drug plan and what is the uncertainty that remains. Originally, the O'Malley administration had directed, for purposes of saving money, that retirees be shifted from the state retiree plan to the regular Medicare Part D plan. But that never took effect after a lot of objections were filed. And the latest situation is that there's still a lawsuit pending, so that the state employees retiree plan will remain in effect through the end of 2022 at least. Hopefully there'll be a decision on the lawsuit before then, and it'll be known what's going to happen in 2023. At the moment, that is not known. So that's the basics on the state. And that's probably the place where I should stop for now. And hopefully you have some questions that Andy and I can try to answer.
Okay, we're opening it up now to any questions. We had said to put it in the chat, but if you want to take your off of mute, you can also ask a question directly. Does anybody have any questions?
I would also just say that was a great case study by Jim on what the hoops he had to jump through to find the most affordable option, and he's an expert. So I think it was just a great example of the process that you have to go through.
I guess while waiting for other questions, Jim, Andy, let me ask you a quick question. So you work at the state level, or you working with other organizations? I see a lot of other states are planning similar types of boards, or maybe they've already put them into place. Are you forming some collective groups together to try to push things at a regional or national level?
Yeah, that's a great question. So I would say I'm not aware of any formal coordination or anything like that, but I do, so when it comes to the legislation, it's often the advocates that get that across the finish line. We are more here as a resource and group of subject matter experts, and we're always happy to share our experience. So our neighbors in Colorado just created a prescription drug affordability board, and we're always happy to share lessons learned. And we'll always also be looking at other states too, to kind of see if there's options that can work for Maryland. So that's all to say, states are always trying to work together, often in an informal network, but it's just great to see progress in other states, and we're hoping that we can lead the way in Maryland. So.
Thanks, because I know in some cases states get together for purchasing collectives and other things where they do build policies and do build purchasing solutions. So.
Yeah, and the purchasing collectives is actually a really good example. That's one of the policies that we're specifically researching. So there are scenarios where we could potentially be partnering with other states to, bulk purchase and things like that. So that's a good point.
Okay, Jim, I have a question for you. You spent most of it talking about Medicare and the Plan Finder, and maybe this one for Andy as well. Are there any specific websites you would recommend for people who are not on Medicare where they can get help in a similar way? Looking at I know some of it probably goes back to the health plan that they're under, or maybe their employer or something.
Okay. In terms of general sites, and maybe Andy knows of more of them, for prescription drugs, I'm not sure what a real good unbiased site would be, and that's the only kind I want to direct you toward. I wonder if CMS has some of this kind of information on its site. Andy, do you know about that?
Yeah, for CMS, I think the Plan Finder is the best resource. So I would say for folks that are not on Medicare, first go through your employer. That's step one. If you are currently employed or retiree, see if there's health plans that are available through them. Otherwise, we have the Maryland Health Connection, which is the exchange site, and there are often very affordable options on there. And when you go through that exercise, you want to do the same thing and making sure that it's the right plan for the right drugs that you are on. So I would reference you to that, and then also a lot of great support from the Health Benefit Exchange team as you work through that process if you decide to go through the exchange. And then finally, unfortunately, it is kind of a hodgepodge of where these other, patient assistance programs are. So I would start by just Googling, the drug that you're on and patient assistance program and see what comes up. Often they're going to be either directly from the manufacturer or potentially from nonprofits that work in the space related to the disease or the drug or something like that. And then always you can go to the resources that Jim mentioned, the GoodRx, which is effectively a PBM for the uninsured, as well as the OptumRx ARP tool. I'm not sure if there's any specific qualifications for using that. So I think that's kind of from a high level. Also, the Prescription Drug Affordability Board is considering ways that we can try to consolidate these resources and kind of have a one-stop shop for folks that are trying to find all the tools that are available to help make drugs affordable. So it's not, on the street yet, but we're always happy to help work through some of these issues if anyone wants to reach out to us directly.
Great.
Specific questions.
A couple of questions have come in through the chat. Jim, did you want to handle the first one?
No, yeah, sure. Let me look at it first here. I am seeing one that says apparently this is AARP's current initiative to modulate drug pricing under the current constructs. Is there any consideration directed to a national health insurance implementation? Okay, just AARP has, if the thrust of the question is, are we backing a Medicare for everyone kind of drug pricing situation, AARP has not taken a position on that kind of thing and is unlikely to do so in my view.
Okay, thanks, Jim. Actually, there was a question before that from Sue about Plan D, and maybe that's one that maybe that's an Andy question. Do you see that one, Andy?
Okay, I see that question. Maybe if Andy could take the first shot, I'll have something to add on that.
Sure. So that's kind of, again, a quirk of the way the plan structures. And I actually thought that they had tried to eliminate generics in brand name tiers. So just on the back end, what's happening is brand names are actually giving such a high rebate to the plan that it's cheaper for the plan to use the name brand drug than it is for the generic. And if you just think about it, that's not how it's really supposed to work. So I think it's kind of just a quirk of how these plans are working. I know Medicare, at least 2 years ago, was looking at creating rules to prevent name brands, generics from going onto the name brand tiers and name brand drugs going onto the generic tiers. Though apparently it sounds like this is still a recurring issue. And then you also have a question on how often they can change the formulary. I'll have to double check, but they can change the formulary maybe like once per year or something like that.
It is normally once per year unless there's a specific strong reason for doing so.
Yeah. And go ahead, Jim.
Also, this is where the tier 6 kind of situation comes in. If a Part D insurer has a particularly advantageous arrangement with a manufacturer, they'll just put the drug on tier 6, which didn't even exist in many not too long ago. And you just got to check there and then see if what the drugs are in particular plans. It bears no logic a lot of times.
Okay, we have time maybe for one more question if anyone else has another question. Okay, I don't think anyone else is. I want to thank both of our speakers, Jim and Andy, for the time they spent and the information. We'll also have information on follow-up, and will also be the slides will be going out to the people who participated in this. And now